Welcome to the GOTA virtual conference. Scan the QR code on the left to participate in our silent auction. The silent auction will run from October 1st to October 29th of 2020. Scan the QR code on the right to go to the GOTA online store. Thank you to our 2020 sponsors. Platinum level sponsor, the Shepherd Center. Gold level sponsors, All About Kids Therapy Services in the University of St. Augustine. And silver level sponsor, Hanger Clinic.
Good evening, everyone, and welcome to our second evening of GOTA virtual conference sessions. It is my distinct pleasure to introduce our speakers for the first session this evening, entitled Considerations for Occupational Therapy Practice in Primary Care Working with Refugees. Dr. Jade Gross is Clinical Assistant Professor in the Georgia State University MScOT program. She has developed and taught foundational OT courses, clinical OT courses, and the community-based practice course that features some community programming components, including with the refugee population. Her clinical experience as an OT includes a motivation to serve refugees in the community using her background in psychology and practice as an OT for over 8 years. Her clinical work includes rehabilitation for general medicine conditions, orthopedic conditions, neurological conditions, lymphedema, and breast cancer with adults and older adults. In her current faculty role, Dr. Gross aims to continue strengthening community partnerships with local nonprofit organizations that serve at-risk and marginalized groups, including those that serve refugees. Ms. Temple Moore is an occupational therapist with a master's degree in global health and development and a certification in global mental health from the Harvard program in refugee trauma. She utilizes her various fieldwork and volunteer experience with displaced persons in national and international contexts. She recently completed qualitative research on the effect of occupational engagement for the mental health of asylum seekers with a history of trauma living in the UK. Temple currently works with the Refugee Women's Network managing their Community Health Promoters Program, where she combines trauma-informed OT skills with public health research and storytelling for refugee and immigrant populations in Atlanta, Georgia. So with that, we will begin our session. Thank you for being with us tonight.
Thank you so much, Irma, for the introduction. It's great to be here. Thank you guys for joining us on this Tuesday evening. I'm especially excited to have my previous professors here, Irma and Mary and Jennifer, and all of you here. So Jade and I started collaborating on this research pre-COVID, and we are excited to share with you this project. So I'm going to share my screen and we'll get started. We are going to have you guys put questions in the chat, and we've left 10 minutes at the end for those questions. All right, so today we're talking about considerations for occupational therapy practice in a primary care setting, working with refugees. Our learning objectives are to summarize first the current practice of OT with refugees locally and globally. We'll then have Jade discuss OT in a primary care setting locally and globally. And then we'll analyze the components necessary to tailor practice delivery in a primary care setting working with refugees. We want to keep this research and discussion in line with the AOTA vision, which is looking at occupational therapy as an inclusive profession that maximizes health, well-being, and quality of life for all people, all populations and communities through effective solutions that facilitate participation in everyday living. So we really want to uphold those pillars of that vision that look at, being effective leaders, being collaborative, increasing access, and especially equity, inclusion, and diversity. So who are refugees? Many of us know about the UNHCR definition of refugees as people who have had to flee their country because of persecution due to race, religion, nationality, members of political groups or social groups. Something people don't often know about resettlement in the United States is that most resettled refugees, they're the unique, very small minority that get to come over to the United States. And they are not choosing where they're going. They don't even get to choose the country. It's the UNHCR that typically finds the most vulnerable people in a refugee camp and decides that they, they're vetted and chosen to come over here. Those are typically involving people that are children at risk, women and girls at risk, survivors of torture and extreme violence, and people with complex medical problems. So when we look at the local and global context of OT with refugees, we want to think about what are their health concerns. So when refugees present in the US, we see a significantly higher level of psychological disorders, including PTSD, depression, anxiety, and psychosis. We know that often there is a history of trauma due to experiences happening before they were displaced, but also during displacement. So that includes presenting with emotional symptoms of trauma, but also the physical symptoms, so actual injury and chronic illness, and also the idea of psychosomatic pain, what we often see in refugees. Displacement as trauma is a newer way of talking about, not only are people forced to flee their country, but the journey itself and then the experience of having to adapt to a new culture is also quite traumatic. We also want to consider the effects on health of socioeconomic loss, delays in education for children, loss of employment, and what that means to be in a new country where you can't necessarily have the job that you were trained to in your previous country, your home country. We also want to consider vulnerability for certain groups of refugees, people with disabilities, asylum seekers, those that aren't protected yet under refugee status, survivors of torture, unaccompanied minors and separated children, the homeless, and single parents with young children. Common barriers to getting equitable healthcare include language and cultural barriers, socioeconomic constraints like transportation and getting childcare, and discrimination within the system. Why does it make sense that OTs would work with refugees? So present throughout the history of OT is the recognition that the profession brings value to the context of displacement. We acknowledge that initial conflict and the escape together with seeking asylum or being resettled introduces obvious disruptions in daily roles and routines. What are those disruptions? Work, education, development or use of life skills, identity, family and social roles, community integration, community engagement, general well-being and quality of life. All of the research that OT and occupational science fields have explored in refugees looks a lot at what happens in their occupation, during the journey, but also once they're resettled, and looking at things that aren't just about work and education, but really a sense of identity, things, what it means to not feel belonging, or even a sense of being valued in that new culture. One particular study I often refer to looked at or found 3 themes. They looked at about 24 articles on this experience. And the themes were occupational deprivation, occupational imbalance, occupational adaptation, occupational change, efforts to maintain and reestablish identity, and outlook for the future. So these are the typical areas that are challenged for refugees resettled in the US and other countries. When we talk about occupational deprivation, that's something we see a lot. It's not just a temporary disruption in occupation, but it's a state of preclusion from engagement in occupations of necessity and or meaning due to factors that stand outside the immediate control of the individual. And I think that that's something that is unique to the refugees who are so impacted by policy and legislation, what their citizenship status is, and what their access is, whether formally in policy or just perceived ability to access certain things in a new culture that's difficult to navigate. So how does OT work with refugees? How do we provide services? Well, we need to look at the lack of social resources. We need to look at things like social stigma and these established political and humanitarian responses to, this was supposed to be another bullet point, these external things, but then also the internal factors, right? So the behaviors and both of those things need to be considered, these external and internal factors, and then the cultures that they bring with them. And what OT can do is bring a strength-based intervention. So looking at reconnecting people to their identity, helping them adapt to the new culture, but not abandon their own culture, bringing structure, bringing activities of daily living back to refugees, and really looking at community integration. So the power, again, of belonging and feeling valued by the community you live in, and also bringing trauma recovery approaches that accompany looking at participation and occupation. Just checking my time. So when we look at what OTs are doing with refugees, there's a plethora of areas that OTs can work with. So life skills, education, employability, social inclusion, arts and leisure, various areas of health, resourcefulness, community integration, and then more specifically, volunteerism, transportation, medication management, chronic disease management, financial and health literacy, home safety and maintenance, cooking groups. So we see that there's, various settings physically and sort of areas of occupation that can be addressed. Occupational therapy, as you probably all know, is not something that we don't see a lot of OTs hired as OTs to work with refugees. These are non-traditional settings. We often see OTs through research, through academia, that are working with refugees. We see them as volunteers. And so this is often in a community-based setting. So whether that's an organization in the local city that serves refugees, or sometimes in that volunteer sphere, it's often not in standard medical settings that we see occupational therapists working with this population. And I think that's important to consider when we think about what it means to be, for example, myself, I'm hired at Refugee Women's Network, not as an OT per se, but I'm bringing my skills as an OT. And I think that that's something that we need to, support as we look at this context as necessary for OTs to be in. So I wanted to give specific examples of OTs that are working with refugees. Dr. Smith is an occupational therapist and professor at the University of Utah, and I actually did a field work with her in 2013 through Brunel. And she's had this program for a long time where master's students work with different refugees from various countries. They do life skills training. They look at very specific challenges that are tailored to each refugee as a person, as their own unique challenges, and they are able to help in various areas. One thing that's I appreciate about her program is also the Karen Weaving program. These are refugees from Burma who they are supporting to preserve their traditional weaving from their home country, but also it brings women together, it creates community, and they sell their products, so it's helping give them some socioeconomic support. So it's a very great program. Another great program is Jade and Carolyn's, who are from Georgia State, and my colleague here today, who are working with Friends of Refugees on a field work in Clarkston. Again, they're working with a very unique multicultural group of refugees. OTs are put in the classrooms with young children. This is a group of under 5 kids while the mothers do other classes. And the students are developing activities to support those children, especially the ones that need extra support, and then be able to make that support sustainable by teaching parents what they're offering to those kids. Another example of practice is my colleague Theo, who is in Greece. Again, he's hired as a livelihoods office and project manager, but he's an OT at heart. He's about occupational justice. It's about, people have to do purposeful things, whether they're in a refugee camp or a city dwelling. Also in Cyprus, we have, again, it's practice, but it's through academia, looking at employment mentorship workshops. Pride is an American organization in Illinois, I believe, yes, that is multidisciplinary. We have occupational therapists working with other rehab professionals, national grants given, looking with a participatory occupational justice framework, looking at employment for refugees with disabilities. So a very specific targeted group, many people coming together to serve this community, and hired OTs as OTs. Another example is a woman in Phoenix who saw a need and created her own NGO to provide occupational therapy for services for refugees that were needed. Back in the Netherlands, they do a lot of research and work with refugees, and my colleague that I've worked with out there, Nadine, did an interesting study where she worked with refugees to explore the role and the definition of OT. So really putting the refugee at the center, their voice being held up, which is really important. And when we do research and work with refugees, this is another example of where education and research overlap. This group out of North Dakota that created a manual for working with refugee populations. I think we're doing okay on time. So those are specific examples which I want to give to show the great things that are happening, but also how much room there is to grow. So in 2014, WFOT made a statement that OTs are positioned to play a significant role in enabling displaced people to bridge former and current contexts and meet human needs, human rights, and health through participation in valued and meaningful occupations. I think a lot of our national organizations, state organizations are in support of OT in this context, but there are lots of barriers to getting OT there. And I hope that we make strides and we can all partner together here in Georgia to change that. There is not very much research on refugees in primary care, but we do find that primary care is often the first point of contact for refugees with the healthcare system. So it's very important. There was one particular study I wanted to highlight that looked at the refugees' perspective on communication. We understand that there's a language communication issue often, but there's another communication barrier, which is more cultural and also has to do with, in this setting, it was, the doctor given authority, the doctor didn't raise the topic about trauma, And the patient didn't bring or have a sense that trauma and those personal experiences are related to health. But once that was introduced, they were really interested in discussing trauma as its effect on health. So I think that communication barriers come in many different ways, and as OTs working with refugees, we really need to have a culturally responsive approach. And that really starts with looking at ourselves. What are our implicit biases? How do we think about culture? What does it mean to be an OT, an American, maybe white OT, working with someone from a different race or ethnicity and culture? And how does that impact our relationship as a therapist with them? So I think really being reflexive of our own positionality in these areas is extremely important, and working collaboratively with other disciplines, with interpreters, is extremely important. So I'm going to pass along to Jade. Thank you so much for paying attention and listening, and I look forward to your questions as well. So thank you so much. I will stop sharing now.
Thank you, Temple. So as Temple mentioned, primary healthcare is often the first point of contact within the healthcare system. And really, as the first point of contact, this may be one of the most ideal places to most positively influence refugee health through OT practice. So just to back up a little bit, I want to provide a couple of definitions. So primary care is defined as the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. So looking at primary care, there's a difference between what we think of as primary care versus primary health care. So primary care is more of the traditional concept of what we think of as primary care. So those services provided by physicians, nurse practitioners, physician assistants, to be able to diagnose, treat, and manage illnesses. So kind of that traditional medical model. Versus primary healthcare tends to be more comprehensive and holistic, focusing on those comprehensive and interdisciplinary services, those services to provide preventive and curative treatments that also include rehabilitation professionals. So those rehabilitation professionals that may include occupational therapists, with a goal to improve patient health, support community development, and manage chronic diseases. So again, a much more holistic approach with the concept of primary health care. So looking at OT's role in primary health care, in 2012, there was an AJA article published called Defining Primary Care, Envisioning the Roles of Occupational Therapy. So in this article, we really saw the groundwork and foundation laid for why OTs need to be working in a primary healthcare setting. It was also kind of like a call to action for OTs to branch out to working in this particular practice area. This article talked about potential opportunities for OTs in this setting under the expansion of the Affordable Care Act during that time. And also in this article, they cited a lot of international examples of OTs working in primary care practice, especially in those countries that already had this, laid the groundwork for strong community-based practice OT presence. Also in 2012, Sherry Muir published an article called Occupational Therapy and Primary Healthcare, We Should Be There. And in this article, she nicely outlined what are the OT qualifications for primary healthcare, and essentially, making the case for why OTs are qualified to practice as primary healthcare practitioners. stating things about how OTs have background and knowledge and training of things regarding human development. So human development regarding cognitive, physical, social, emotional aspects. The OT training and knowledge and background of health promotion and disease process intervention, our expertise in activity analysis and behavior modification, OT's understanding of how to provide lifestyle interventions and how to train people in using adaptive equipment, all of these skills necessary for to be able to work in a primary care practice. Additionally, in Muir's 2012 article, she provided tangible examples of what that general role of OT in primary healthcare practice would look like. So the first one, the first OT role in primary healthcare would be to assist the physician in early intervention to prevent disease or disability, to reduce the impact of the disease process, and compliance. So here really taking a preventive approach and working with to complement the services the physician's already providing. The second role of OT in primary healthcare she outlined was to provide services that extend the ability of physicians, nurse practitioners, and physician assistants to be able to provide more holistic care, focusing on identifying how symptoms are actually affecting function and participation. So one of the things commonly identified in primary care practice by physicians especially is there's such a limited amount of time they get to spend with patients. So adding another healthcare provider, such as occupational therapy, to look at patients more holistically, and specifically within the lens of looking at occupational function and participation would be helpful. The third role of OT in primary healthcare she outlined was to improve patient satisfaction by addressing a broader array of patient issues and thereby demonstrating a concern for more than just symptom reduction. So a lot of times when people go to a primary healthcare provider, it's based on some symptom they're experiencing, and that's generally the approach a primary care provider physician takes is, reducing or addressing whatever symptoms or complaints the patient has. So with OT practice to help improve patient satisfaction by addressing issues and looking more holistically rather than just at the symptom reduction. The fourth role she described was for OTs to be able to provide simple interventions that can be done at home or with intermittent supervision before referral for extended interventions, such as those may be provided by specialist care. So here, occupational therapists can provide home programs and help oversee those programs with patients in primary care practice. The next role she outlined for OT in primary healthcare was to enable or improve participation in occupations through activity modification or adaptive equipment and techniques. I mean, this right here is just basically like OT's wheelhouse. This is what we do, and focusing on improving participation and performance in occupations. The last role she described for OT in primary healthcare included the concept of group education and group interventions to address prevalent issues among that particular population served. So these could be group interventions provided by OT, such as improving physical activity or diet modification, nutrition, things like that could be provided in more of a group setting. So Smith et al. In 2020 looked at specifically what would be common, what are the common interventions provided, those specific interventions that OTs provide in a primary healthcare setting. And before I talk about those common interventions, I just want to back up a little bit and say, an OT who works in a primary healthcare setting really has to be able to focus and function as an OT generalist. So it's a broad scope of practice that OTs in primary care are, across lots of different types of interventions for clients across the lifespan. So OTs have to work kind of to be able to work and function as a generalist. So common interventions that Smith et al. In 2020 found OTs providing activity modification in primary care, durable medical equipment or adaptive equipment training, education about self-management routines, sleep hygiene, stress and pain management, maybe including some home programs to include things like stretches and strengthening or other patient education, So again, just some common interventions that are used by OT in primary healthcare. More specific examples of OT's role in primary healthcare, Popolazio and 2018, some of the most common diagnoses that are seen in a primary healthcare setting, and took those common diagnoses and looked further about what specifically OTs can address regarding those, kind of more from the physiological standpoint, but also from the behavioral standpoint. So for example, one diagnosis is diabetes. So an occupational therapist working with a patient who has diabetes may work with them on medication adherence strategies. And from a behavioral perspective, maybe on coping strategies regarding the diabetes, particularly if it's a new diagnosis. Another example of a common diagnosis seen in primary healthcare includes low back pain. So an occupational therapist can work with a patient with low back pain, providing education regarding posture adaptation during daily activities. And from a behavioral perspective, working with that on coping strategies, maybe around the loss of function they may be experiencing. Maybe that client or patient is experiencing loss of employment, loss of meaningful recreation, or change in family roles. So from a behavioral perspective, OTs can work with that particular patient on coping strategies around those different areas. So this table kind of nicely outlines, again, some of those common diagnoses that are frequently seen in a primary care practice setting, and what specifically the OT's role would look like when working with those patients. We see a lot of international examples of OTs currently working in primary healthcare. So Bolt et al. In 2018 did a scoping review of occupational therapy interventions in primary care. And this scoping review focused primarily on Europe. And they gave examples, they noticed examples of OT interventions in primary care that range from being provided in the home, interventions provided in the community, as well as the traditional primary care clinics. So some general examples of types of interventions that OTs were providing in primary care practice settings included assessment and retraining of skills and activities, educating on symptom management and how to manage health conditions. OT interventions included adapting activities, assistive technology training, as well as adapting the physical and social environment. And also general interventions included to be able to support the caregivers and family members of those presenting to primary care. There were also some specialist interventions noted within this scoping review. So examples of specialist interventions provided by OT in primary care included vocational rehab and reintegration, working with patients on fitness to drive or driver's rehabilitation. OTs were providing specialist interventions regarding lifestyle coaching and promoting social inclusion and community engagement. OTs were advising on technical and adaptive devices. And there was even a specific example about an OT that provided a dance program for older adults. On the map on this slide, it's a little bit small, so you may not be able to see, but I circled some of the countries where they found these examples of OTs working in primary care practice. So they found over a handful of examples of OT in primary care practice in the Netherlands. They found a couple of examples in Norway, a couple of examples in Ireland, a couple of examples in Portugal, and one in Spain. So just to kind of give you a picture of where OTs in the world are practicing in primary care settings. Another article in 2016 looked at occupational therapy in primary care, specifically in Canada. So those OTs in Canada that are working in primary healthcare practice settings and what types of interventions they're providing as well. So this table, again, it's kind of small, but this table lists all of the different interventions and services provided by primary care practice OTs. So at the top, we see examples of equipment prescription, OTs working in falls prevention, health promotion and prevention, OT services provided around wheelchair and wheelchair mobility, as well as home safety interventions. So again, it just kind of outlines where OTs are working in primary care practice in Canada and the types of interventions that they're providing. So we see these international examples of OTs working in primary healthcare. However, when we look at the United States, there's not a lot of examples provided in the literature. In fact, here, it's still considered an emerging practice area here in the United States, and we see that described in the literature, despite a strong support that we get for this practice area from the American Occupational Therapy Association, and as well as from ACOT. So there's a lot of challenges for OTs practicing in primary healthcare here in the United States. And some of those challenges largely center around the concept of understanding and communicating OT's distinct value and role to primary healthcare practice. So this includes OTs ourselves understanding what our role is, as well as to be able to communicate that role to our role in primary healthcare and our value that we could bring to primary healthcare, and communicating that to primary healthcare providers, to policymakers, to potential sources of funding, as well as to the general public, and to understand what our role and value is in the setting. Another challenge regarding OT's presence in primary healthcare involves initiating a relationship with primary care providers. So this kind of goes back to the previous point of to be able to communicate our role and our value within a primary healthcare setting. And if we're able to do that to primary healthcare providers, that will help form and bond a relationship with those primary care providers. Another challenge for OT's presence in primary healthcare includes modifying this concept of traditional OT service provision and how we can translate that to a primary healthcare practice setting. So thinking about what are these, looking in the OT practice framework, what are these common interventions the OTs are providing, and how does that translate? What does that look like within a primary healthcare practice setting? And then the last point on this slide, and looking at the challenges of OTs in primary healthcare, is the uncertainty regarding reimbursement for OT services in this setting. So it's important to be able to identify potential funding sources to help overcome this challenge. So thinking about, Temple really laid the groundwork for OTs working with refugees. I've talked a bit about OTs working in primary care practice settings and how these are kind of both a little bit still emerging. They're a little bit challenging for OTs to get into both of these settings. So what is required to blend both of these emerging practice areas? And just kind of generally speaking, it's essential to have an understanding of the barriers to accessing primary health care by refugees. It's essential to have an understanding of the benefits for OTs working in primary health care with refugees. And it's important to understand how to advocate for the presence of OT in primary health care, OTs working with refugees. So to elaborate a little bit more, and Temple covered this some as well, but understanding those barriers to accessing primary health care by refugees, thinking about common barriers refugees experience, such as language, accessing interpreter services, the various types of diverse cultural barriers that refugees may be experiencing when accessing primary health care. Issues surrounding health literacy and knowing the patient bill of rights when seeking healthcare services. And even from a logistical standpoint, for refugees to be able to access primary healthcare services, to be able to have access to transportation, to be able to get to your healthcare providers, or childcare services for someone to watch over your children so you can, keep that doctor's appointment. So just some of the logistical things to think about as well. And back to having the understanding of OT in primary healthcare setting for refugees. So again, I've kind of laid the groundwork in describing, the benefits of OTs and why we're qualified to be in a primary healthcare setting, but particularly for refugees. So again, OT understanding of the physiological, the neurological, cognitive, psychological, social, cultural factors, thinking holistically about how we view individuals and how those concepts affect human performance. We're able to holistically develop occupation-based interventions that respond to the unique individual and group and community health issues that refugees experience. OTs are trained to be culturally competent and to provide sustainable health interventions that promote continuity of care, to think about that transition from primary healthcare to the community setting, so the carryover of what we're doing, thinking about how we can transition from more of that medical model, that treatment-oriented focus, to more of a holistic, more preventative care way of thinking. And then specific OT services for refugees could further branch out into the areas of women's health, focusing more on mental health, home safety and modifications for this particular population, promoting health literacy, as well as healthcare access for refugees. And again, how we can advocate for OT's presence in primary care working with refugees. So again, when we're advocating for this presence working in primary care with refugees, to be able to understand our value and our distinct role first and foremost, and to be able to communicate that with that value and distinct role to policymakers, to medical professionals, to other interdisciplinary services, as well as the general public. And again, that value of OT, having OT in that integrated healthcare model. So more specifically, it's important to think about how you would specifically create a plan for infusing OT in a primary healthcare practice setting working with refugees. So again, back to the first step, to having that strong understanding of both the scope of OT practice working with refugees and the full scope of OT practice working in a primary healthcare setting. So having that foundation is important. The second step would be to create a personal and a community inventory. So the personal inventory really requires one to think, about what your intrinsic assets are. Qualities that are important for a primary care OT, they need to be assertive and confident in their skills. They need to be able to work well interprofessionally, to be able to accept feedback and adapt to rapidly changing needs of the setting and patient population. Skills that an OT needs to have is to be able to work as an OT generalist, as I mentioned before. So to be confident to provide skills across our full scope of practice. So really thinking about those intrinsic qualities and being very introspective about that. The second piece is the community inventory of the community that's served by the particular primary healthcare practice. So specific to refugees, understanding those refugee health, understanding and identifying what the demographics look like that are served by the primary healthcare practice. And then within the practice itself, what are the resources and relationships already established by the primary healthcare practice? And how can thinking for the OT, how can the OT utilize some of those resources and relationships? The third step would be to fully understand the structure of the clinic or organization and its philosophy that the OT is trying to, merge into practice with. So understanding the structure of the clinic and organization, who are those key stakeholders and decision makers for the clinic, building relationships with those individuals and planning with those individuals. And then the second piece is to develop a deeper understanding of the clinic, understanding the clinic's mission, their vision, their values, their philosophy, and how OT can really complement and contribute to those mission, vision, values, and help the OT clinic or help the clinic meet these goals by providing OT practice. The fourth step would be to identify the provider's needs. As I mentioned before, there are certain limitations that healthcare providers working in primary care practice have identified, such as limited amount of time to spend with patients and things like that. So really working with the clinic to figure out what those providers' needs are within that particular clinic. The fifth step is to identify the patient needs. So again, understanding the patient demographics, understanding what languages are spoken, are there interpreter services available within the clinic, and regarding the patient needs, what are some of the common reasons that the refugees are seeking care within that particular primary healthcare clinic. And that can be knowledge gained from looking through medical charts and things like that to really be able to fully understand OT can come in and provide care within that particular setting. And then number 6, doing a summary of all of the information gathered in steps 1 through 5. So, you know, the personal and the community inventory, understanding the structure of the clinic, understanding the provider's needs, the patient needs, putting all of this information together, summarizing it, and creating a plan, a proposal for how OTs can plan to, you know, begin within that particular primary care setting. If it's a setting that bills for services, some, you know, clinics that serve refugees provide free services, some bill insurance. So if you're working with a clinic that does not provide free services, thinking about providing a financial analysis also when planning to begin to work with this clinic. So specifically for financial analysis, what could be the gains from OT practice working with that particular clinic? So thinking about some of the direct gains, such as, you know, OTs providing, you know, additional revenue versus some of the maybe more indirect gains, looking at outcomes such as patient quality of life, maybe reduced emergency room visits. So again, kind of evaluating what are the potential gains from OT practice and working in that clinic. Also under financial analysis, thinking about the projected CPT codes and reimbursement from those codes. So, and the picture in the top right of this slide gives an example from Smith et al. In 2020 of different CPT codes that an OT in primary care practice may bill for, what those reimbursement rates look like, and how you can sort of determine what the projected revenue per day would be. Another part of financial analysis is thinking about what would be the anticipated patient volume, how often would be the OT be working in that particular practice, how many patients would the OT anticipate seeing. And then the last step of this is thinking about the cost of the program. So in table 2, on the bottom table on this slide, thinking about what the salary of the OT would be, the benefits required OT, any travel or education expenses, therapy supply expenses. So these would be important things to think about too when creating a plan for how to incorporate OT within a particular primary healthcare practice for refugees. So I outlined kind of some of the steps for OT practice and working in a primary healthcare practice with refugees. And as Temple outlined too, that refugees are experiencing a myriad of health issues. Refugees are at high risk for developing lots of different types of health conditions, chronic conditions, and they're experiencing barriers to accessing healthcare. And if refugees are able to access healthcare, they're at high risk for fragmentation of healthcare. So fragmentation meaning that they receive healthcare, perhaps at a primary care clinic, and they're referred to perhaps a specialist healthcare provider, and for whatever reasons, they're unable to, or there's a long amount of time until they're actually able to see that specialist. So that's kind of what is meant by that concept of healthcare fragmentation. So there are a lot of opportunities for OT in a primary healthcare setting and working with refugees. Primarily, the first opportunity is to really serve refugees, providing occupational therapy while minimizing that risk of healthcare fragmentation. OTs have an opportunity in the primary healthcare setting working with refugees to be able to provide holistic care, to increase a patient's ability to receive holistic care during their primary healthcare visits. And lastly, OTs have a real opportunity in a primary healthcare setting working with refugees to be able to overall influence and ideally improve the health and wellness for this population that tends to be at risk or marginalized. So to improve the health and wellness for these refugees as well as their families to overall improve the health of our community. Here are references, and that concludes our presentation.
Thank you. Temple or Jade, would you like to entertain some questions?
Definitely.
I don't know if you all, you can just say your questions. You don't have to take the time to put them in the chat box. Comment?
This is Mary. Thanks for a great presentation. I really appreciate your specifics about the interventions. And I love, Jade, you were reading my mind, girl, like about, I was like, okay, how would we bill? How would we pay? Blah, blah, blah. And you do have to think about the pragmatics of this. I'm wondering, just specifically, I mean, like the way I envision, and I'm assuming you and Carolyn are doing this, getting your foot in the door through a university clinic partnership. Is that what you're doing? Or if you're not, how might you envision that?
So we have not yet started, but we are exploring, Temple and I are exploring reaching out to clinics to begin kind of starting this process, but it's not something that we've initiated as of yet. Our current work is really within the Friends of Refugees Family Literacy Program, so more of a school-based early intervention type setting.
Mm-hmm.
Sorry, I don't know if I answered your question.
Yes, yes. I mean, I think it's like I'm thinking of maybe certain clinics that, like we had in Gainesville, something like Good News at Noon, or something like a clinic, like a free clinic that maybe serves more refugees, and somehow using it as a level one, once COVID's over, a level one fieldwork experience to start with, you know, and strategically building it up, which, like, I would envision at some point, maybe they would have an OT there, 0.25 or 0.5 FTE or something like that. But I could see this being like an OTD project too, to sort of create their own role in a setting.
Yeah, and I think some of the things that you talked about, that's definitely our goal in moving forward with this project. We kind of just sort of started with this idea this year, and we're kind of doing some of the groundwork to, you know, eventually go toward that direction.
And Clark,
You should recruit Robin Underwood. Like, she's retired now. She'll probably help you with this.
Yeah.
yes, we appreciate any suggestions. And we, you know, Clarkston, we didn't speak specifically about the clinics there, but there are specific clinics that are free or that, or and or predominantly serve refugee and immigrant communities. So those are the ones where we would want to get to know their needs and talk to their staff and create those relationships.
Right. Temple or Jade, where can an OT anywhere in Georgia find a database or information on any refugee organizations or services within the state or the region?
It's a really good question. There are several resources, but one is CRSA is a collection of refugee service organizations, and I'll put in the chat. And then there's also a new website called clarkstonresources.com that I'm working with the developer on to create kind of a directory of different health, financial, and family services for refugees and immigrants. And, you know, two of the big clinics in Clarkston are the Clarkston Community Health Center and Ethna Community Health Center or Health Clinic. Those are two big ones. They're doing a lot of COVID response. And anyone that's interested in getting more resources or involved in any of these Clarkston projects and organizations, please contact me. I'm really hoping, we're all hoping that OT is going to be have more of a presence in Clarkston.
This is Kay. Nice to see you in Temple. So we have done some work around fall prevention at the Good News Clinic, which is a pro bono clinic in Gainesville, and some of the barriers. Well, right now we're not doing it with COVID, so it's a big whole barrier, but have really been language oriented. Probably about 60 to 70% of our folks have had very limited English skills, and so reliance on interpreter and the skills of the interpreter have been very difficult. Sometimes we've had to rely on family members, which of course we all know we shouldn't do, but when they're there and they came for the clinic and they've had the taxi ride and whatever else. And so I just was curious about your experiences and suggestions you have to, like a lot of them can't read. So like even having it translated, that's not so much of a factor. It's really being able to communicate with them in their language. There's just so many barriers in place to that effective communication.
Yes, and I think we have to finish by 8, but I will say that yes, being sort of resourceful and creative and acknowledging that sort of the rules that happen in a hospital may not always happen in a free clinic for refugees, and just thinking on your feet and being creative, and sometimes using online tools to be able to demonstrate things, because you have so many people that are illiterate in their own language. So yes, just getting it Google Translate's not going to help you. So you really have to have that sort of, and also interpreters are great, but then you've got another relationship and you don't know, so you have to create a relationship with that interpreter and create trust with them, so that you create that avenue for a trusting therapeutic relationship. So there are so many things to consider, and I think it's a really important point that has to be considered, and really that being pragmatic. You can't put a framework always in these settings. You really have to think on your feet and how to solve. But I think on an OT in an integrated setting like that, in a clinic, you could anticipate and have more systems in place to be responsive.
I think we do have to close, but just remember your role as an advocate, and these programs do run on federal and state dollars, and they do have policies that state the rights of people, and their rights are not advocated enough. So that's a place to be. And I'm afraid we're going to have to leave and get to our next session. But
thank you
both so much.
Thank you.
Thanks, everybody.
Please email us.
Yes.
Okay.
Thanks, everyone.
Thank you.